it's okay. Our ACCLINO Flex experience since 2020, it was summer, and in 2 years, we already used 77 stents, and in 8 cases we used for aneurysm, and 69 stents we used for 55 patients in stenosis cases. Location of the aneurysms. And for the aneurysms, we usually use the ACCLINO Flex stent for the emergency when the coils are prolapsing. And this is an example. We treated this MCA aneurysm patient, and at the end of the balloon deflation, coils start migrate, and we placed 4x20 ACCLINO Flex, and coils kept inside the aneurysm. This is a case M1 segment stenosis with the MCA wide neck aneurysm. We did NeuroSpeed balloon angioplasty, and then we placed the Neuroform Atlas 4.5 by 21 millimeter, and then coiled the aneurysm through the NeuroSpeed balloon. Stenosis. As we know, the most important trial was the Sampris trial, and in Sampris trial, the all complication in medical management group was 5.8%, and in our hands, the treatment of the elective patients should be 5.8% complication or less. It's the margin we planned, and in PTE group, in this study, the complication was nearly 14.7% of morbid mortality. 195 patients we treated in 6 years, in last 6 years, and mostly it was males, median age 61 years, and most of them are working patients between 45 and 74 years. Location of the stenosis, the mostly it's internal carotid artery and V4 segment of the basilar artery, and the rest is basilar V4 segment of the vertebral. The rest was the basilar and middle cerebral artery, and the most important part of the patients who could has the perforator occlusion was nearly 20%, and for the ACCLINO stent, this is the best group for the treatment, because M1 segment in last 4 years, since 2016 till 20, we tried to send this group of the patient for the bypass, but after starting to use ACCLINO Flex with the NeuroSpeed balloon, most of this patient we start to treat endovascularly. This is profile of our patient. 99% he's a hypertensive. In 50% he has diabetes, 1/3 coronary disease, and 25% after myocardial infarction, and underwent bypass or stenting. 59% has hypercholesterolemia, and 60% was active smoker or present smoker. Previous stroke has 66%, 1% of them has hemorrhagic stroke, and 12% has TIA, 15% after previous interventions for other location of the stenosis. Complication in stenting group mostly is a ischemic complication, 10%, 10 patients, and 1 patient had a deadly hemorrhagic complication, and all of them in total, 0.7% of complications. Medication for the angioplasty patients is aspirin 100 milligram daily, and in stenting group, nowadays mostly we switch for the ticagrelor, and if the ticagrelor is effective, we check all these patients with the verify now aggregation testing, and we try to treat all of them mostly monotherapy. We have seen the cardiology literature data, and nowadays ticagrelor mono antiplatelet treatment is effective and safe, and we do it in neuro patients. The stents we used since 2016, all 254, and for ACCLINO Flex for the last 2 years is 60 stents. It's nearly 24% of all stents we used. And most of the stents we used was coronary stents till 2016 exclusively, but last 2 years we use more and more self-expandable stents. Location of the stenosis, it's ACCLINO Flex group, the most of them in M1, M2, basilar, and V4 segment. For the ICA stenosis and vertebral stenosis, we try to use more balloon expandable stents, and for the supraclinoid and paraclinoid ICA, we change for the ACCLINO Flex. Balloons and wires we used, it's coronary balloons, and last 2 years it's NeuroSpeed, and wires. In all cases we try to use Xeon Blue, it's a coronary wire, or other coronary wires, because it gives stability and pushability of the NeuroSpeed balloon like all other coronary balloons. Cases since 220, it's a patient with the both vertebral artery stenosis, and he underwent the treatment in other hospital for the left vertebral artery and basilar artery and right vertebral artery. Was decided for the medical treatment, but patient had TIA and symptoms for this stenosis, and he asked to treat him. We did balloon angioplasty for the vertebral artery and the basilar, and we placed 2 stents, ACCLINO Flex in basilar and in vertebral. And for the last 6 months, we start to use only 4 millimeter stents for the vertebral basilar and 5 millimeter for the internal carotid artery. We stopped to use 3 millimeter ACCLINO Flex because of low radial force. And this is a case of vertebral artery on right side occlusion and critical stenosis on left. The ACCLINO Flex was used through the headway duo microcatheter. And we had complications. Due to intraoperative thrombosis in 4 stents, they were removed, and part of them in aneurysm cases. In the postoperative period, 2 stents in 1 patient were removed. It's nearly 3%, and MRS6 in 1 patient. This is the case of ICA stenosis on right side with no A1 segment on right side and no collaterals. We discussed with this patient about bypass, but the patient asked for the endovascular treatment. We did PTA with 20 millimeter length balloon, and we placed 2 ACCLINO 4x 15. At that time, we hadn't 35 millimeter length ACCLINO flex, and patient went well and discharged at day 5. On day 6, patient was hospitalized in emergency hospital with the signs of stroke. Patient has left side hemiparesis, and our colleagues did CT. CT was clear, and we decided to take this patient to our hospital. We did CT. CT was clear, and we did angio. We expected thrombosis because patient didn't take ticagrelor in the evening and in the morning on following day. And we tried to do aspiration and thrombectomy with solitaire. It was bit effective, but after 15 minutes, artery was closed, and we decided to do stentectomy. And after stentectomy, the artery closed again, and we decided to place 6x30 solitaire. And before the thrombectomy, we gave to patient 2 pills of ticagrelor, 180 milligram. And after placing the solitaire, we decided to place the bypass, and this angio after bypass, the bypass is patent, and solitaire is also patent. And patient was discharged at day 8. The MRS was 2. I think the cause of this complication was placing 2 stents. It could be quite thrombogenic, but the most reason is human factor. Patients stopped to use ticagrelor after discharge. If you have questions, I would be grateful, and thank you for your attention. Thank you. Paul?
A couple of questions. You have presented some cases with stenosis in the ICA segment, in the cavernous segment. What's your opinion about the ACCLINO flex adaptability in this location?
Nowadays, if there is a not so tough angulation, we try to put coronary stents, but when the angulation more than 90 degree, it's impossible sometimes to push the coronary stent, and then we switch for the ACCLINO flex.
Mm-hmm. Okay.
It's only the indication is angulation of ICA.
Okay, my second question is about the removal of the stent. If I have understood well, you present a 5% of stent that were removed because of acute thrombosis. This is correct. And what about the technique to remove the stent?
Yes, the case I showed, we placed 2 stents, and it's like conventional thrombectomy. Just place the solitaire inside, little bit distally, and pull all construct with the thrombus inside. Yes, usually it works, but sometimes couldn't. But other 5 stents we retrieved. We had a technique we call Kazakh thrombo test. We place the stent and wait for 15 minutes. If there is some kind of thrombus, intraoperatively, we couldn't inject any alteplase or reoprointegrelin. Reoprointegrelin is not available in our country. Then we decide to not to leave the stent inside the artery. Usually it's partially open stents, and it's not so problem to take it out.
Okay, but how do you remove the stent? With another stent, what do you use?
Stent is not completely deployed. It's
Okay.
partially open. Then we just take it out.
Okay, thank you.
Okay, I got another question, Mynzhylky. So we are back in the topic of elective stenting procedures for symptomatic intracranial stenosis, and your data, when I understood you right, are better in terms of complication rate than the Sampras trial. So we all think about what did they do with the Sampras trial, but there were other trials also not positive for elective stenting. What is your indication? When do you go for endovascular treatment of intracranial stenosis?
The most of the patients had a stroke before the stenting, and we know that we have results a little bit acceptable, and we do angioplasty not optimal. It's undersized balloons, and we place the stents, and we follow our patients, and we see that if we don't touch the M1 segment and basilar with the big balloons and the big stents, usually they went well and there is no complications. And in our country, we have a lot of these intracranial patients with stenosis, and we see that the perfusion decrease is one of the indication. The other indication is symptoms. It's TIA or previous stroke in the same vessel territory. And I think the technique is not so complicated, and we treat a lot of extracranial stenosis. Why we shouldn't touch the patient with intracranial? If we do low rate of complications.
So that means when you have one stroke or TIA due to an intracranial stenosis, this is a qualifying event for you, no? So in Germany,
Yes.
for example, after Sampras, we have to wait for the second one under so-called best medical treatment, and you don't wait for that second event under medication.
Yes, and and you know, from the group we are discussing about the medication in Kazakhstan, we check all patients for the aggregation through the verify, and in clopidogrel patients, more than 45% they're unresponsible. The medication is not effective, and as we know from the Sampras, the best medical treatment is aspirin and Plavix with the statins, and if the medication is not effective, how we could discuss about the best medical treatment? Yes, and in stenting patients, we use aggregation tests, and we use ticagrelor.
Okay, thank you. One more question. In former times, you were always, I know you are a skilled neurosurgeon, and you were always in favor of bypass surgery. And the topic of your talk was how the habits or the practice has changed in your country. Do you still, in an MCA stenosis, do you still consider bypass, or is it now more the endovascular approach?
Nowadays, it's more endovascular because we have tools and it's safe and effective. And as we noticed, in nearly 15 patients with the M1 stenosis, we placed bypass, and in more than half of them, the bypass was occluded because M1 was patent. It's a concurrent flow, and like in coronary arteries, if the coronary artery is patent, and then bypass could be occluded in 5 years for 70%. It's the same situation with the M1, M2 stenosis.
Thank you. So some more questions from the audience? Somebody?